Greetings, everyone. Welcome to the 120th session of the online Optom learning series. And for today's session, we have with us Dr. Kwang Cham. Dr. Kwang is a senior lecturer at the Department of Optometry and Vision Sciences at the University of Melbourne. He completed his PhD in 2008, where he worked on investigating the internal states and visual performance in patients with infantile nystagmus. He has previously run the Neuro-Optometric clinic at the Melbourne Eye Care Clinic, along with a neurologist, and he has assisted with assessing nystagmus patients at the Eye Movement Laboratory with Assistant Professor Larry Abel. He is also the coordinator of the management of neuro-ophthalmic disorders and online master's subject. Currently, he is supervising an ophthalmologist from China who is undertaking her PhD in nystagmus. And with the recognition of the teaching excellence, Dr. Chams has received the Melbourne School of Health Science Teaching and Learning Award in the year 2019. He has vast experience working with patients with nystagmus and also some educational field as a background. Number of publications in this field as well. And I was fortunate to present one of his recently published paper in terms of education as a part of my journal club at IACL. So that's how I got to know Dr. Cham, and we then connected, right? And yes. Today he's going to talk to us about how should we go about the neuro-optometric assessment, understanding the infantile nystagmus syndrome. So welcome, Dr. Cham, onto our platform, and let me leave the screen time to you now.
Yep. Thank you, Fakhruddin, and I'm very, very honored to be invited to present to you guys and share with you, I guess, my learning in this area. So a very good morning to you guys, and it's actually afternoon here in Melbourne. It's cold and winter, that's why I'm wearing a jacket. So please, by all means, ask any questions and post in the chat box, and I can address them at the end of the session. So I'm going to go through, I guess, one of the learning objectives as being an academic. We want to learn how to conduct a very basic neurological screening examination. You want to be familiar with what the clinical features and assessment of infantile nystagmus syndrome, previously known as congenital nystagmus. So the terms have been used quite loosely in the literature, but the current terminology is INS, infantile nystagmus syndrome. And last but not least, we want to develop understanding of the literature regarding therapeutic intervention for INS. So this will serve as a good basis of foundation when you discuss with the patients of the parents of the kid who have nystagmus, able to provide some advice in this area. I have the privilege of working with Dr. Neil Shui, a very well-known neurologist in the University of Melbourne and across Australia. And with him, we set up what we call a checklist for neurological testing in an optometric setting. So it has to be practical and clinical to us, not what we cannot do as optometrists. You'll be familiar with a lot of the tests that I've posted here. We do not do the full refraction. It's very targeted. So it's VA with your current RXF pinhole if it's the vision is worse than 6/9. We do M-slip plus red cap testing, to test the brightness or saturation of the redness, to assess the function of the optic nerve head. We do Ishihara as the monocular color vision testing and up to 17 plates for classification. We do pupil sizes in bright and dim, RPD, your relative afferent pupillary defect or your Marcus gun, and we also test for DCN, which is your direct consensual and near responses. Ocular excursion are very important, noting that whether there's any restriction or overaction or limitation of your eye muscle, and particularly any double vision or any pain on eye movement, which is what EM stands for. We do very quick, a very gross inspection or smooth pursuit, with your letter H or with a pen or with a finger, just getting the patient to, can they smoothly track a moving target? And it's the same with your saccadic movement, again, just with two fingers, keeping their head very still, whether they can alternate their gaze right and left, up and down, and also at an oblique angle as well. We test for convergence, unilateral alternating cover test. We use the automated machine, so we routinely test the blood pressure and heart rate of every single patient in the consultation room as part of your optometric practice. And of course, we then supplement with fundus photo, macular and optic nerve fluid OCT. We do visual field. We don't do the neurological testing. Often that takes very long, and usually these patients are quite sick. So the central test, MedMon or your Humphrey 30-2 is actually quite sufficient. So this is the, I guess, the protocol or the entrance test that we put every suspected or someone with a neurological complaint through. But really what I want to focus more on this talk today is about cranial nerve testing, mental, cerebellar, sensory, and reflex testing. You know, I admit that when I first started as an optometrist, I never knew that I could do that. I never thought of doing it. I always thought that this is something I always refer. But you know, the practice and the landscape has changed in the last decade. And you want to think about, you know, if you're not a diabetes expert, not a glaucoma expert, not a contact lens or pediatric expert, you know, what else could you do something differently in your practice? What other services could you offer? You know, that's going to differentiate you from other optometrists. And this is something that's actually not that hard to do once you get a hang of it. So I'm hoping to encourage you to at least give it a go in the next patient that you see. Let's first talk about assessment of lid function or ptosis. You know, you're going to see droopy eyelids at some point in your practice. And by eyeballing or just trying to say, I think that lid's drooping down is actually not scientific enough. And at the University of Melbourne, we teach our students these 4 aspects of, you know, how do you assess lid function. So we look at the palpebral visual aperture, and that's quite easy to measure the distance between the upper and lower eyelids. We look at the marginal cornea reflex. So in the photo, you can see MRD1 and MRD2. So basically, with a pen torch, you get the central corneal reflex, and you measure the distance from the superior lid to the central corneal reflex and central corneal reflex to the inferior lid. And the table will give you the measurements, what's considered normal and what's abnormal. So I do bring this table with me when I see my patients. You know, I can't remember. There's so many numbers that I have to remember. The levator function, we got to ensure that there's no forehead wrinkles, there's no brow movement. So patient look all the way down, zero your ruler, and then look all the way up. So this is a levator function. And the last but not least is your lid crease. So in the photo, it's detailed as MCD. So this is your marginal lid crease. So distance from your upper lid margin to the lid crease. So we do not do 1 or 2, we do all 4 measurements. And then for us to decide, does the patient has a ptosis or not? Is the lid drooping? And is it normal or normal physiological, or it's more acquired or pathological? So very simple measurements that we can assess the lid function relatively easily. We talk about the mental screening of it. So we go by the acronyms FORCS, you know, family, orientation, general information, and spelling. This is the type of patient that during history taking, you know, you do your external observation, watching for ptosis or lid retraction, abnormal head posture or head turn. But at the same time, you get the patient to express themselves. They can describe what they are wearing. They can describe the surrounding of the room. They can tell you what you are wearing as well. You want to see whether they know where they are in the physical time and location and environment. You can ask them, what day is it today? What's the time now? Give them a couple of words like dog, fish, cat, or car, and 5 or 10 minutes later, get them to repeat it to see whether the memory is being retained. You can give them something like the world or optometry or famous, and I get them to spell forward and backward. Very simple screening. Remember, all the tests that I'm introducing you today are screening, not really pure diagnostic, but they do determine the urgency of referral. And I'm going to tell you why I think we should be doing that later on. So what exactly are we targeting here? So this is the cerebrum higher order and thinking function. So remember, the right side controls the left motor function and vice versa. We've got the 4 famous lobe, the frontal, parietal, temporal, and occipital. Now, we are good with occipital because we do visual field, we do VA, but what about the mental function, the personality determination, how they express themselves? So the frontal is divided into the anterior and your posterior aspect of it. The parietal and temporal will depend on their speech processing, whether there's difficulty with their smell and whether there's a difficulty with hearing. So I'm going to touch on that when we look at the cranial nerve testing. So very simple mental screening, give you a feel of where the lesion could be or what difficulties the patient might be struggling with. When we assess a cerebellar function, so this is the finger to nose test, and it's very simple. Again, our patient need to be able to listen to my instruction. So I will say, with your right hand, index finger, can you touch the tip of your nose? And you find that it should be fairly easy by doing that instantly. So they should not be trying to, locate where the tip of their nose is. And then the second stage will be, after touching the tip of your nose, can you touch my finger? So I will then move my finger in their field of vision and get them to try and touch the tip of my finger. So it's the finger to nose test. Again, very simple test to perform in your consultation room. We get them to do some rapid alternating movements. So I will put this, I will get them to follow my pattern to see whether can they rapidly alternate or twist their wrists as I'm doing it. So are they able to follow my instructions or not? When we look at tandem gait, so this is the heel to toe. So they have to be looking straight ahead and not looking at the floor. So they should be able to walk in a straight line, the heel to toe, are walking in a straight line. So this is a type of the test that sometimes you see on television that the police will pull over someone who they suspect has been drinking alcohol. Can they walk in a straight line or not? So this is the tandem gait test. Now, the rhomboid and dynamic rhomboid is quite useful because remember, a patient who has a problem with proprioception, they can still maintain their balance by compensating with vestibular function and vision. Okay, so the whole idea of the rhomboid testing is I'm going to eliminate. I'm going to, get you to close your eyes. So I eliminate your vision. Can you still maintain balance or not? So basically, I get the patient to stand up and just close the eye. So I'm there holding the patient in case they are swaying, in case they might be falling over. Now, if there's a loss of balance, we record that as a positive rhomboid sign. In some patients, it can indicate ataxia. Ataxia is like abnormal, uncoordinated movement, and commonly it can be due to a dorsal column disease and impact our proprioception. Dynamic rhomboid requires the patient to stick their hand out. This is like an arrow, and they could march on the spot and with their eyes closed. And after 10-20 seconds, get them to open their eyes. They should still be pointing straight. If they point to the extreme right or to the extreme left, that often indicate the site of the vestibular lesion, which is either on the right or left, depending on where they are pointing. So again, very simple test, but give you, a bit of an idea of what's happening here. What should I be targeting in terms of the patient? The cerebellum controls eye movement and a lot of the motor control. Does not cause total paralysis. They have very uncoordinated balance and very jerky movement, posture difficulty. So remember, your cerebellar lesion often affect the same side, unlike the cerebrum. Yeah, it's the same side affected. They have saccadic over undershoot, and they often can give you a jerk type of nystagmus. So this is your involuntary oculomotor oscillations that you see in cerebellar lesion. Before I move on to cranial nerve testing, it's this is just a quick reminder, which cranial nerve are sensory and motor and mixed. So if you look at cranial 1 to 4, innervated by the midbrain, 5 to 8, the pons, and 9 to 12, and the medulla. So they form the brainstem. So again, if you think about cranial nerve 4, 5, 6, 7, 8 being affected, straight away you can target, I think, in terms of the brainstem, what am I looking at? Is it the midbrain and the pons, and not really the medulla? But if this patient has got swallowing difficulty, the tongue is not straight, as in 9, 10, 11 just affected, straight away, in your letter of referral, you could just say that, well, you suspect this is where the lesion could be, might be, and you get and the patient will request further investigation. That is very impressive coming from an optometrist, trust me. And again, not hard to perform once you go through the cranial nerve testing. We are very familiar with 2, 3, 4, 6. Yeah, we always do 2, 3, 4, 6 as part of your normal optometric consult. You realize that I've omitted cranial nerve 1. Cranial nerve 1 has been, a bit unreliable at times due to there's a lot of patient with allergy, blocked nose, hay fever, which is quite common in Australia, and hence we have choose not to do cranial nerve 1. If you want to do cranial nerve 1, what they do is cover each nostril, and you get their smell gels that's commercially available, or they can just smell the coffee bean. But again, it's very subjective. Patient needs to be able to distinguish that there's differences in in their smell. I'm going to jump straight to cranial nerve 5. Cranial nerve 5 is a 3 division. You have the ophthalmic maxillary and the mandibular. Now we do corneal sensation with the tip of the cotton bud. So sometimes you do that when there's the herpes simplex infection of the cornea. You want to see whether there's decreased corneal sensation. But for this, we use the neuro tip. So this is actually more accurate. So what this does is, can the patient differentiate between something that's blunt, if I take this off, and something that's really sharp? So this is what we'll do. We'll get the patient to close their eye. So with their eyes closed, what I do is, can they tell me whether it's sharp or blunt? So I'm testing the 3 division with their eyes closed and watching whether there's asymmetry from the right or left side of the face, or whether there is any asymmetry between the division. So this is a more accurate assessment of your cranial nerve 5 than just the cotton bud. Now, if you don't have one of these neuro tip in your practice, anything's better than nothing. You can still use the tip of the cotton bud and just see whether they can feel the sensation or not. Cranial nerve 7. Yep, this is where get the patient to smile, whether there's any asymmetry. When the Bell's palsy, their smile is often a bit crooked. Get them to puff their cheeks. And you want to press to see whether there's any asymmetry in the resistance or not. Now, sometimes when the cranial nerve 7 is affected, their taste may be a bit affected as well. So this is one of the questions you might be asking if you're suspecting a Bell's palsy or cranial nerve 7 being affected. Do they have some taste differences? Obviously, if the patient has got Botox, their face aren't really going to move. So it's very important that we know whether they have got Botox before. Cranial nerve 8, it's vestibular. So it's hearing and balance. Yeah. So this is the nerve that has got multiple tests. I'm going to go through the finger rubbing first. Again, this is very simple to perform. I get the patient to close their eye. I stand behind the patient 40 to 50 centimeters apart, and you rub the fingers. They should be able to tell you whether they hear finger rubbing on the right or left side of their ear. So that is a very simple test to perform in terms of finger rubbing auditory testing for cranial nerve 8. We also use what we call the tuning fork. So we do have a set of tuning fork in the clinic as well. So I do perform hearing tests. I'm not an, audiologist, but this will give me what this will give me is, if you look at the table, whether the patient has got normal hearing or sensory neural or conductive. So this is the air conduction versus the bone conduction, which is the bony region behind the ear. What we get students to do is they're going to pluck it. The tuning fork will vibrate. So we'll bring it close to the ear, and we'll get the patient to respond as soon as they can hear. So this is the air conduction we are testing. Then we pluck it again, and this time we place it at the back of the ear, whether the patient can again hear or sense the vibration. So they should respond much faster in terms of the air versus the bone. So this is what we expect in most cases with normal hearing. However, I cannot rule out whether there's a sensory neural loss, because you can see this is the Rhine test, the air conduction is always greater or faster than the bone conduction. If the reverse is true, we can suspect there might be a conductive loss, which we could attribute, oh, there might be a middle ear infection, refer to GP for further testing, and that might explain why the patient feels a bit, wobbly, a bit unbalanced or not coordinated. So cranial nerve aid, we have our finger rubbing and the right test to test hearing. And in the other cartoon where you see the patient on the hospital bed, this is the whole pipe testing. Now, we do have a hospital bed in our clinic, so we don't routinely perform that. But what we're trying to do here is we're going to shake the patient head gently, for 30 seconds to a minute. And as we keep doing that, and we stop, and we get the patient to lie on the edge of the bed. So their head is half hanging on the edge of the bed. And then we bring the patient up. The first thing we look for, is there any abnormal eye movement or any jerk nystagmus? So if that's happening, well, why is it so? Why can't the patient maintain fixation? What's happening here when we try to disrupt the vestibular function? So this is cranial nerve aid testing. 9, 10, 11, 12, not what we routinely do, but what GP usually do. 9 and 10, very, very simple to perform. Yeah, you get a tongue depressor and get a patient to say, ah, and that's what you are doing. The GPs often get you to do that. We say, they want to look at the back of your throat. So what are they assessing? Your cranial nerve 9 and 10, they want to look at whether the palate and the uvula are rising symmetrically. So any asymmetry, you're going to suspect cranial nerve 9 and 10, it's a bit affected. Now we don't do the gag reflex because we do not want patient really vomiting on us. So we do not try to do the gag reflex. For cranial nerve 11, we get the patient to shrug their shoulders. So I'm going to press down on their shoulder. They're going to try and shrug up, and I want to see whether there's equal resistance or not. And the same thing with turning of the head. So I'm going to hold their head really still, and they're going to try to turn either to the right or to the left. So I'm going to see again whether there's weaknesses on one side or not. And cranial nerve 12, basically, just stick out your tongue. So the tongue should be straight. So as you can see, if I put all this together, get the patient to smile, puff their cheek, raise their eyebrow, shrug their head, shrug their shoulder, stick out their tongue, and say, I've basically tested a series of cranial nerve already. So it's actually not hard once you think about what you're testing and trying to put this together as part of your consult. So typically, you will take 5 minutes to do a full complete cranial nerve testing in addition to your 2, 3, 4, 6 once you're familiar with it. And students who are listening to this, practice is perfect. You just keep practicing this, and this is something that you don't need a consulting room to do this. You don't need a chair or phoropter or slit lamp or the VHR, something you can actually practice outside before you try to do it on a patient. And when we talk about neurological patient, we're not talking about those that's got tumors, or diseases, history of stroke, migraine patient, persistent headache. These are all neurological complaints. So don't think about the big dramatic lesions that patients are dying. Think about what a common neuro complaint. I've got double vision, suspected myasthenia gravis, multiple sclerosis. These are some of the common neuro diseases that you're going to encounter at some stage in your career. We next move on to sensory testing. So again, this is the neuro tip that I've just shown you before. So this is the sharp edge and this is the blunt side. So again, we get the patient eyes closed. This is now on their hands and feet. Diabetes can affect, numbness or tingling sensation of their hands and feet. So can they still differentiate what's dull versus a sharp sensation with their eyes closed? Whole idea, you really got to eliminate vision, yeah? And proprioception of the big toe, again with their eyes closed. Basically, whether you bend imagine this is a toe, you bend it up and down, and the patient should be able to tell you without even looking at it with their eyes closed. So this is your, periphery autonomic nervous system, whether they have got intact sensory sensation. The last but not least is your reflexes. You test your pupillary reflexes because you do pupils testing. You can test your blink reflex, as your cotton tip is trying to test your corneal sensation, the patient will blink. With the knee-jerk reflex, so we have got what we call, hopefully you can see this here. This is the hammer. This is the hammer that we do for the knee-jerk reflex. You might have it tested before when you've injured your knee. So what we do is obviously get the patient to sit on a high chair so their leg is half hanging, and we're going to tap below the bent knee on the patella tendon. So when we tap on the patella tendon, what it causes the quads muscle to contract, the leg should bring forward. Now, obviously, when you're doing this test, you do not want to stand in front of the patient because the patient is going to kick you. The Babinski reflex. We are still using the hammer, making sure people can see the hammer because of the virtual background. And what we do is, this is the sole of the feet. We're just going to stroke it. It's almost like, if you like, I'm going to tickle your feet. And in the adult, what will happen? You're going to curl down. This is what's going to happen, yeah? Now, in an infant, actually, they don't curl downward. They actually fan outwards. So this is the Babinski reflex, yeah? In infant, they curl, they fan outwards. But in adult, as you tickle the soles of the feet, they curl downwards. If you get an infant response in an adult, that is something significant to observe. So this is the Babinski reflex that we are testing. Now, reflexes, if you look at the stimulus receptor model I have on the right side, where you got the eyeball and the brain. So really what we're trying to do here is to look at the periphery nervous system. So this is the reflex arc, yeah? So this is the stimulus response model. So you get the pathway of a nerve impulse from the sensory receptors along the motor neuron to the spinal cord. So these are all parts of the periphery nervous system. And when you test all these reflexes, it can quickly tell you how well all these nerves are working as well. So we have gone through, I guess, a checklist. I've shared with you the checklist that we teach our students in terms of that neurological testing in an optometric setting. I've talked about the cerebellar testing. We talk about the Fox, the family, the orientation, the spelling. So this is a cerebrum. And we talk about finger to nose test, the tandem gait, the rhombus testing, and we talk about your cranial nerve testing. So the focus on the 3 division, puff their cheek and get them to smile, raise their eyebrow, shrug your shoulder, flex your head, stick out your tongue and say, putting all this together is a pretty comprehensive neuro-optometric screening. And in supplement with your other clinical testing, you got a pretty good idea of what the patient has. And that's going to help you, what do you do next? And if you want to review the patient, how often should you review? That will also tell you, do you refer to a GP or do you refer to a neurologist? Do you refer to a neuro-ophthalmologist? Who do you refer to? So gathering all this information is something that we optometrists can do. So we do not just prescribe glasses and contact lenses. We look at diabetes, we look at glaucoma, we look at macular degeneration. We prescribe contact auto care. We do myopia control, but we can also do neuro-optometric screening. And remember, these patients are those that come with persistent headache. Sometimes they might tell you that, I don't feel well today. I've had taste difficulty. I feel a bit weak. Sometimes it pays to listen a bit, and you might be, surprised what you can actually discover. Remember, you got to perform the test to say that they are normal and not just assume they are normal. So this is the first half of my presentation. And next, I'm going to move on to infantile nystagmus syndrome. I'm not sure how many of you have encountered abnormal eye movement or a nystagmus patient before. Hopefully, this will give you some idea or background, or at least prep you the next time you see someone with abnormal eye movement. But before we do that, if people could look at the poll, how are you confident assessing a nystagmus patient in a consulting room? That might give me a bit of an idea, in terms of. So 5% is very confident, 26% is reasonable, okay, 47% somewhat, and 21% not. That's very interesting, because in the Australian landscape, most of them will fall somewhere between maybe somewhat and maybe not quite confident. And of course, that depends on what we talk about assessment, or how I define what's a proper comprehensive assessment of nystagmus patient. Thank you. So I'm going to move on. So involuntary ocular motor oscillation. So the eyes are wiggling, manifest at or shortly after birth. So usually birth, we see that in infants, even in toddlers, even as young as 6 months, very rarely in later life, but the literature has reported that it sometimes can happen in later life, and it persists throughout life. Yeah, this is a lifelong condition. It doesn't really disappear. Most of them have an underlying order of the visual system. So foveal hypoplasia, albinism, congenital stationary night blindness, optic atrophy, and approximately 30% has got some form of strabismus, be it an exo or eso, hypo or hypotropia. Yeah, let me go back to this again. Yeah. Characteristics, it's bilateral. The bilateral and conjugate, very similar amplitude in both eyes. Both eyes behave really, really very similar. It gets worse with fixation effort. Okay, so if they're trying hard to see, their nystagmus gets really worse, and they can sense that their eyes are oscillating much faster. Fixation effort means, and it depends on their stress and motivation level as well. So you think about a nystagmus kid trying to sit examination, trying to getting their vision checked, before they can take their to get their driving license. This is something that is going to be stressful for them. There's something that's motivating for them. Their nystagmus actually get worse. Their VA actually deteriorate. It damps with convergence. That's why we do testing. We do near point of convergence. As they converge, nystagmus oscillation actually reduce with lid closure and is abolished by sleep. So they do not feel the eyes oscillating when they're sleeping at night. So these are the characteristics that's been proven. Dell also is a very famous nystagmus researcher. He himself has got nystagmus. So he's definitely one of the leading experts in this field. When we talk about the clinical features, often is what waveform. So RNS have got 12 different types of waveform, and how we describe the waveform by amplitude, frequency, intensity, and foveation period. So hopefully this diagram will give you a good idea of what we meant by the amplitude, which is the movement of the drift, the eyes drifting away from fixation, and then there's a corrective movement in the opposite direction. So the amplitude is measured in degree, and again should be very similar in both eyes. We've got the frequency, which is the number of cycles per second measured in hertz, and intensity is amplitude times frequency. Foveation period, if you look at the diagram, that's the flat bits. So remember, when the eye are oscillating, the eye are constantly moving. But if you look at the waveform closely enough, there's actually there's almost a flat portion. So that's where it's almost stationary. It's almost stationary and not quite moving. So this is the window where the nystagmus patient have got very good vision. The intensity and the foveation duration and the waveform, it can change in different gaze direction. So ocular excursion, as you're doing it, sometimes you find the waveform seems to behave a bit differently, and the waveform may also change with age. So the waveforms are actually quite variable. All this amplitude, frequency, intensity, foveation period can also vary when they look at different gaze direction. So there's no standard fixed set waveform for a particular nystagmus patient. It can have a latent component, which is a change with occlusion of one eye. So what it means that if I'm just covering one, so with both eyes open, let's say, this is how the eyes are behaving. And when I cover one eye, the eye starts beating in the opposite direction. So this can happen. And what we meant that, the INS has got a latent component. Very important. This oscillation remains horizontal. So regardless whether they're looking up, down, left, right, the oscillation remains horizontal. So it should not be vertical. It should not be rotary. It should not be torsional. It should not be oblique. It should just always be horizontal. So this is a very important diagnostic indicator. It decreases when the gaze is directed to the null zone. So you hear about the null zone. So this is the field of gaze where the nystagmus intensity is minimum and as best foveation period. And that's why sometimes when they got a null zone laterally, they come in with an abnormal head posture. So they will come in with a head posture of face turn or a chin position where the eye oscillate less. And if you take vision in that direction, in that setting, it does give you improved VA as compared to primary gaze. So I'll have some waveforms examples to show you at the end of the presentation of what I meant or what's the effect of this null zone. So it does minimize the nystagmus intensity and maximize the visual acuity for them. So what are the tough questions that I suggest you should think about asking when someone comes in with, I guess, wiggling eye or abnormal eye movement? So of course, in addition to your normal routine history, asking about medications, drugs, previous history of surgery, infection, trauma, so on and so forth, family history of nystagmus, do they ever experience ortholopsia? So ortholopsia, by definition, is the perception that sometimes the whole world is moving, like things are moving. Okay, sometimes they feel like things are moving when they're not supposed to move. So they're not crazy. So this is almost like an illusion to them. So acquired nystagmus, constant ortholopsia. Now with INS, sometimes they get it, sometimes they don't. So whether they experience this ortholopsia before. Does it get worse when they're tired, stressed, or sick? So again, due to their stress level, motivation level, they get worse with fixation effort. So it will get worse when they're tired, when they're stressed, when they're sick, they're not feeling well. And whether they have a null zone, so this is where they turn their head and face to your preferred position, they see better or the eyes wiggle less. Now, acquired nystagmus will not have that. This is very classic for congenital nystagmus. And the parent will notice that whether the kid has done anything unusual or different when they're reading or playing with toys. Sometimes, we know convergence will dampen it. Sometimes they bring things too close, not just myopic. It could be nystagmus if they got abnormal eye movement, or whether the child tend to move their head turn or head tail or face turn in what they call acute way, but actually it's not just habitual, something's not quite right. And obviously, I'm asking the teacher whether they've noted any issues at school. Then as an optometrist, I've got this nystagmus patient sitting in my room. Can I do all the tests that I need to do? The answer is yes. You can do slit lamp, you can do direct ophthalmoscopy, you can do fundus lens examination, you can do BL, they can do visual field, you can do all the tests, but you know that the eyes are always going to be wiggling. So you do need to troubleshoot. You might be getting a bit of snapshots of the retina image or the cornea that you're seeing. So you really got to be much quicker than that. But very interested in VA and refraction. They have to be provided, the best refraction. So I get them to look straight ahead, and I probably won't cover one eye, especially if they have a latent component. How the nystagmus might change. Rather than using a total occluder, like a black occluder, I might just put a blur lens in. Usually a plus lens should be sufficient enough. So just like a blur lens in the untested eye. So straight ahead, let's get the VA, and then with the preferred head posture, we get the VA again. So the null position again will improve the VA because it reduces the effort to see. It can reduce the nystagmus intensity. So you want to see what the differences are. That's going to be useful when you think about lenses to prescribe, which I will tell you in the next few slides. Unilateral and alternating cover tests are very useful. I almost do it a bit slower because apart from looking at the misalignment of the eye, whether there's a tropia or a large fovea, I need to look at the nystagmus beating direction as well as I'm doing it. So usually I'll do it a bit slower. I want to see, does the nystagmus change direction or not? Now here, apart from a latent component, to make things a bit sticky, a bit more complicated, there's something called a periodic alternating nystagmus. So this type of nystagmus is very different. It changes direction after a certain interval. It requires very long eye movement recording, not something we can see eyeballing, but something you should be suspecting if you think there's a change in direction, apart from having a latent component. Ocular motility, mask test to perform. Does the nystagmus change when looking at different gaze direction? So remember, it should always remain horizontal. It should not be vertical or oblique. It should not change. It should remain horizontal, even if they are looking straight up. Okay, oscillation remains horizontal. Very important diagnostic indicator. And convergence, if it damps to convergent, more likely a congenital form of nystagmus as compared to acquired form of nystagmus. At the University of Melbourne, we think that eye movement recording has to be done. It has to be critical. So at our eye movement laboratory, which is run by Associate Professor Larry Abel, who is actually my supervisor when I did my PhD back in 2008, also one of the leading experts in congenital nystagmus. He runs the eye movement lab, and we collaborate with a lot of pediatric ophthalmologists who refer to us for eye movement recording. Less invasive, much easier to perform as compared to a CT MRI scan in a kid. By eye movement recording, we can determine whether the patient has got congenital or acquired, and also what type of nystagmus that the patient has. Now, I'm not going to go through the diagrams here, but as you can see, those pendular or I guess your jerk nystagmus or velocity slow phase, you can't eyeball that by clinically. It's impossible. So if you go to pendular, it can indicate INS. So one of the 12 forms is a pendular nystagmus, but at the same time, it can also indicate brainstem and cerebellar diseases. So obviously, this kid has to be well and healthy, apart from wiggling eyes, nothing of concern as compared to some of the brainstem or cerebellar disease. If you look at the linear or what we call a velocity slow phase type of waveform, OKN is optokinetic nystagmus, VN is your vestibular nystagmus. So it can indicate more of your physiological forms of nystagmus. Accelerating velocity slow phase, this is diagnostic of INS. The moment we see this type of waveform, this patient has got infantile nystagmus syndrome. So this is a type of waveform we're looking for when we think the patient has got INS. And the last diagram is almost the flip opposite. This is the decelerating slow phase. It can be physiological or it can be pathological as well. So you realize that the one in blue I call infantile, FMNS. So it's fusion, maldeveloped nystagmus syndrome. It's very similar to INS, but also congenital, very similar characteristics, but the main difference is their waveform looks different. So with the eye movement recording, they almost behave identical. So again, I stress that it's very important to perform eye movement recordings in nystagmus patient. Therapeutic interventions. So we have gone through the clinical features. What are the characteristics? What are the questions I should ask as an optom? We've gone through what are the, in terms of VA and refraction, motility, cover test, MPC, the key test to perform. What can we do about it? Often, I get a parent asking me, so what happens next? What can I do? Is there anything I can do about it? So currently it cannot be cured, but we can try to minimize the intensity. We can try to broaden the null zone. We can try to extend the foveation period. The whole idea is to try to improve the quality of life, giving them better vision, giving them better visual performance, and try to minimize the eye oscillation where possible. So broadly, they can be classified into optical, pharmacological, and surgical interventions. They often have quite significant refractive error and quite high, especially with the rule astigmatism. And this is possibly due to the corneal-lid interaction. So the corneal-lid interaction during the eye oscillation leads to them having very common with the rule astigmatism. Refractive surgery, surprisingly, have also been performed to correct the refractive error, even though you think that the eye cannot remain stationary. It has been performed, but it's not common. Prisms are actually going to be handy. So the version prism, it can reduce the nystagmus. So what we're trying to do here is to relocate the visual laterally. So Patient with an eccentric null zone, rather than having an abnormal head posture, let's move their visual environment straight ahead with version prism. So prisms are quite useful to help to correct some of the abnormal head posture. The vergence prism are also useful, especially when their nystagmus dams with convergence. And very common approach, we begin with a 7 diopter base out, combination with a -1 diopter sphere lens to offset the accommodation facilitated by the prism. So this is commonly prescribed. We can also prescribe a combination of the version and the vergence prism as well. But remember, they are not applicable for large null, which means I've got a very, very extreme head turn or head posture. Only very small degree. We're talking that perhaps less than 20, sometimes 5 to 10, you have got the best chance of success, because you know prism can have, once there's decentration, spherical aberration, very limited field of view, it gets very clunky, gets very hard, you know, when you are prescribing large amounts of prism. Combination of surgery and prism is most beneficial. So with the surgery, they might correct let's say I've got a head posture of 30 degree. After surgery, they correct it. I perhaps have got a remaining 10 degree head tilt. I can use prism to correct that, to move my head into primary position. So this is the most common approach when we think about combination of prism and surgical intervention. Contact lenses, you know, we talk about glasses. What about contact lenses? Several authors have actually looked at it, you know, 1979, you know, and in 2006, 2004, it can improve, not in every patient, but not quite sure why it can improve. Is it because it's better optical correction? You know, you got contact lenses in there, you know, you haven't got the lens effectivity or vertex distance, that's why it's better. Or it's because you got sensory information from the eyelids, like a tactile information. So it can improve, but if you need to prescribe prism, you can do contact lenses. I'm going to skim through the pharmacological treatment quite quickly. So you can have a look here, the baclofen, gabapentin, memantine. So they all have been trialed before. At current, and this is, you know, up till now, there is no randomized control trials. There's no large clinical trials really looking at pharmacological treatment. The success are very variable. It's very hard to compare and contrast. Most of them are case studies. Their inclusion, exclusion criteria are very different. Some are masked, some are not masked, some are randomized, some are not. Some report visual acuity, the improved nystagmus intensity decrease. So very, very, how should I say, very, very sticky, you know, very, very confusing in this literature in terms of pharmacological treatment. And you often wonder the type of improvement that you see in a well-controlled experimental laboratory setting. Does the patient really perceive that benefit when they step out in their day-to-day life? You know, so I really wonder that translation of what we see clinically and how that applies to their day-to-day environment. So very, very, you know, still debatable in the pharmacological aspect. Of course, not without complications and side effects of the medication. So as I said, the optimum dosage, you know, the long-term efficacy, the mechanism by how they suppress or try to minimize the nystagmus is still in investigation, is still unknown. Again, you know, whether that drug-related reduction is more like general sedation rather than a true targeted improvement in the oscillation of the nystagmus. Again, that's also debatable as well. So that's the current, you know, up-to-date literature in terms of the pharmacological aspects of nystagmus. Surgical management. So the principal aim of the surgery, so we're going to shift the null zone to the primary so we can correct the head posture. We want to broaden the null zone. We try to minimize the intensity. So this is the three main aim of why surgery is considered. Now, in terms of INS management, there's 6 main surgical interventions. The first one is the Anderson-Custom procedure. So they recess the rectus muscle responsible for direction of head turn, or the antagonist, or the surgery on all 4 muscles. So whether they targeted the agonist or antagonist muscle, or they do all four surgery. So they are modified or variations of the Anderson-Casterbach procedure. Sometimes they can have a chin up or head down posture, not always just left and right. So the vertical recti surgery, much less common, but sometimes can be performed as well. You have your retroequatorial recession of the horizontal rectus muscle. So they recess all four horizontal recti around the equator of the globe. You have your artificial divergence. So patient, this is where again, if their nystagmus can dance with convergence, and rather than having prismatic correction, you can undergo an artificial divergence surgery. You have tenotomy. So what tenotomy does is they just detach the muscle and reattach the muscle back. They don't do anything to it. They just detach and reattach back. So this is thought, again, the mechanism still unknown, but thought to affect the proprioception, the eye signals from the eye to the brain, and somehow can reduce the nystagmus intensity. And in the last decade, mastectomy, recently, this is one of the newer surgery. So what this surgery does is actually either completely or partially, they just cut the muscle. Okay. And firstly done in US, and something that we don't really agree on, because you just cut someone's muscle. Of course, it stops the nystagmus, but the patient lost all forms of ocular rotation as well, because their eye remains fixed and stationary. So not something that we recommend in terms of surgical intervention. Despite these 6 types of surgical intervention, there's actually no randomized clinical trials. There's no clear consensus about what's the efficacy and the safety of the treatment option. Surgery still remains the main treatment, but they vary in their level of aggressiveness. Some are very aggressive, like the last one I mentioned, where they just completely remove all the patient's muscle. You have to think about the placebo effect as well. Again, there are all case studies, case series, cohort study. There's no no good randomized control trials. If you think about the hierarchy of evidence, we really need a better understanding of the treatment option. We don't know their long-term side effect, but that's required, in terms of evidence-based clinical decision-making in relation to the management of RNS. So I'm going to finish off by showing you some case examples. So these are real nystagmus patients that we've recorded their eye movement in our clinic. So x-axis is the amplitude in degree, and the y-axis is the time scale. Okay, so if you look at the blue line, that represents the right eye, and the red line represents the left eye. Hopefully you can see the black line in between. The black line is just on top of the green dotted line. So ignore the green dotted line. The black line is the target position. So we're able to show using an LED target, which we can show 0 is straight ahead, then 5, 10, 15 is 5, 10, 15 degree to the right, negative 5, 10, 15, 20, then to the left. So we want to see how the nystagmus change as they look at different gaze direction. In this case, you can see that they're very similar in both eyes. Yeah. So this is that bilateral conjugate, similar amplitude in both eyes, one of the characteristics of RNS. You can see there's this increasing velocity slow phase. This is the drift, and then the corrective phase beating down. So this is a jerk left nystagmus, and this type of waveform, very classic infantile nystagmus syndrome. So that's why eye movement recordings are useful and should be performed in nystagmus patient. So again, blue represent the right eye, and the red trace represent the left eye, and the black is the target position. So this is the patient where we move from 0, which is looking straight ahead, to 20 degrees to the right. So that's why you can see the black line, which is the target, is a bit like a step position. And then we get the patient, 0 and 20 degrees to the left. Now, you don't need to be an expert to tell me that, well, when they look to the left, the waveforms has actually looks much nicer, so less jagged. And you can see there's actually the flat bits there. There's foveation period. So obviously that makes sense because the patient prefers looking to the left. Looking to the left, the intensity is reduced and they got foveation period. So the VA is so much better when they look to the left as compared to when looking to the right. But regardless looking to the right or left, both eyes always behave similar. Again, very conjugate, very similar. Also very classic congenital nystagmus. This is the periodic alternating nystagmus that I want to show you. And you can see how the nystagmus changes, So we started off with jerk right. You can see it's still very similar in both eyes. Yeah, the blue and red trace still quite similar. So the fast phase was beating up, and then they enter a zone of this extended slow phase. So they enter a zone of that transition. And then when we record after, we notice that, wow, it becomes jerk left. So it went from jerk right to become a jerk left nystagmus. So this is the type of what we call periodic alternating. So they alternate their gaze direction periodically, and that's how the nystagmus behave. Periodic alternating nystagmus is a bit tricky because their null zone will alternate as well. So they are very tricky when you think about doing surgical intervention because you're not quite sure which muscle should you cut and how much should you cut because the behavior is actually quite variable. But that's up to the pediatric ophthalmologist to determine. They are not really my call or our call to decide. So in summary, I'm hoping that, you will want to try and attempt a more comprehensive neuro-optometric screening examination. And I'm hoping that through this talk, you're a bit more familiar of the clinical features, how do you assess, and what are the clinical signs and symptoms to look out for if we suspect the patient has got a congenital nystagmus or what we call infantile nystagmus syndrome. And I'm hoping that you've developed an understanding of the literature regarding therapeutic intervention. If anything, refraction is critical. I think trial frame is still the way to go rather than behind the phoropter. The prisms do help. The drugs, not so. Surgery is still the gold standard, but there is no randomized control trials. And very pleased to share with the group that recently we just finished our 3 years work of our Cochrane review in looking at surgical intervention. This was published in 18 Feb this year. And the key message is we need randomized control trials. There's no consensus. We don't know what works best, what doesn't work. So we actually have looked at over 450 articles in terms of surgery for infantile nystagmus syndrome. And also, very proud to be acknowledged by the Cochrane group that we are one of the 9 Center for Evidence-Based Vision Care. And with that, here are my details. I hope to connect with you, and we're going to open up the floor to question and answer. So thank you very much.
Okay, great. Thank you so much, Dr. Kwang, for that wonderful presentation. I think very, very important points which are really missed out, I guess. And you did make a point that we normally don't do the cranial nerve evaluation as a routine. When it comes to nystagmus patients, you specifically talked about infantile nystagmus at this point of time. But do you think the examination will be the same for any type of nystagmus? For example, a patient who is an adult, would you do something different compared to the young population, or would you want to add on something?
I think the neuro-optometric screening should still apply. Anyone with the abnormal eye movement or there's balancing issue or whether, persistent migraine, stroke, head trauma, car accident, I think that neuro screening should still apply. What I've given Because usually if they're acquired form of nystagmus, there's a cerebellar lesion or there's a vestibular lesion, those patients are really sick. I don't think we will be the first point of contact. They'll come to us that my eyes feels weird, because the neuro patient that I've seen in the neuro clinic that I run previously, those who are generally referred by GP, and they can't hardly walk. They have to be assisted by their family members. So those are patients are really sick. So I don't think we will be the first point as primary eye care practitioners. But I think more so for it's more of the common day-to-day that you never registered. Oh, maybe this patient might benefit from a neuro assessment, more like baseline, not really trying to diagnose anything, but any baseline is good. So acquired form of nystagmus, we hardly see them because they actually will be in hospital like quite urgent. So those are the people that need urgent CT, MRI scan to work out where the lesion is. So not us.
That's right.
Yeah.
Oh, great. And let's just look at some questions from the attendees. Any thoughts on eye twitching could be due to any neurological reason? Have you come across anything?
It's like blepharospasm. Neuro, you could argue yes or no. And again, anyone who's known in this area, please feel free to comment on it as well. My understanding is that this eye twitching sometimes, it could be habitual. I'm not sure how much evidence, like clinical evidence, is behind it. Some people have said that, if you don't have a good night's sleep, you're too stressed, or you have too much coffee, the eye can twitch. But I'm not sure if there's like a true case for it. I mean, we know it's blepharospasm, and sometimes we often tell the patient, take some cold compress or warm compress, and relieve or decrease your coffee intake. But again, whether is this like evidence-based practice? To me, it's still a question mark. So when I think about twitching, that I'm thinking about the levator, the frontalis, the ocularis, ocular muscles. So the muscles are not under control. So we then got to question, why is it twitching? Like, why is it in spasm? So if this is only a sign or symptom by itself and it's not getting worse, so this is someone that you can monitor. But if this is getting worse, or if there's in combination, and that's why I think this is where my neuro assessment will work up. If I work up the assessment, I found that apart from the eye twitching, there seems to have decreased sensation of one of the division of the cranial nerve 5 or their cranial nerve 7 is not quite what I'm thinking of. So putting all this together, I'm going to refer the patient more likely, rather than I'll see you in a week's time or come back when the twitching has resolved. So again, that's the importance of that neuro screening. Now, and when I say doing all these tests, sometimes don't go for an answer. We will never remember, or will never be exposed to all the millions of the conditions there. It's more of, let's work up this patient first, put all the findings here, and then circle which are the abnormal one, and you want to provide best patient care. So in this context, if I got other cranial nerves being affected, you refer straight away, as versus not doing it and just based on eye twitching. Even I don't know, I might say, be conservative and say do the compressors and come back in a week's time. But I need to be comfortable doing that. So hopefully I've answered your question, but actually it may or may not be. But I'm not aware of like a very specific neuro lesion that one of the key signs is the eye twitching, because the ptosis or the lid retraction is more commonly seen as compared to twitching.
That's right. Yeah. And I think you brought up a very important point on, whether you come up to a conclusion or not. It is important for us to actually do the test and find out what is abnormal, because that helps us when we refer patients to other care professionals, whether it be eye care or whether it be GPs or anybody who is superior, who is going to manage. If they have all these findings, it becomes much more easier for them, as well as it builds up relationship that, this guy does these tests, and you might get more referrals, and, you might co-work together in the nearby future. So I think that's also important.
Yep. Now I think you have actually raised a very valid point, especially in this era when we talk about interprofessional collaboration. You want to work with the GPs, the pharmacies, and the ophthalmologists. So if you're able to write a letter, this type of letter coming from the optometrist, I can tell you, it looks very impressive. They were like, oh, so you can actually do all this testing, not just glasses and contact lenses. They will actually see you differently. And you're quite right. They'll be more willing to work with you because they feel like, actually, I can actually use your expertise and knowledge in this field. And don't be afraid. You don't have to know the condition, but knowing to do the test, put those in your report and send it off. That's one way to learn, and I still don't know all the condition, but I know how to do the test because I've been practicing them, because I need to teach my students how to do it, so I encourage you to practice. Don't worry about if you can remember all the brain anatomy or the visual pathway. If you can't, you can always look it up, but learning how to do the test, the practical, the hands-on, is really what I'm advocating here, rather than memorizing all the anatomy and the visual field defects, so it's actually not all that, because I know that can be daunting, even at times as they go to, is that really that lesion? Is it really that pathway? But at least I've got it in my dictionary to look for it. But without doing all these tests, you actually have no clue where to start looking. So this will help to narrow your gap. And as you do it more often, it becomes more familiar. But you're right, getting that collaboration with other healthcare professionals, if we don't do that, they will always think that we're just prescribing glasses, which is, I'm sure we can all do more than that.
That's right. Really good to know. And is there any role of atropine ointment in evaluation of the INS?
No, not at this point. And I mean, atropine, no more amblyopia control, but no.
Not really.
No role. Any form of ointment or drops, like I said, drugs. I mean, unless there's a systematic review, unless there's a randomized control trial, my personal opinion doesn't represent the whole world. My personal opinion is that I don't think anything is reliable, even if it's just a single case or cases reported that these are useful. But no, I'm going to say no at this stage.
Okay. And any experience on using optics in the INS?
No, it's interesting, and I'm not sure whether it's because of the landscape or how we treat nystagmus patients. So going back to that light therapy and this split optics, if there are evidence-based literature that I'm not aware of, I welcome colleagues to share with me. But I'm not aware that I've got very good solid literature or research to tells me that they will help. So anything that we haven't got research to prove that it helps, we actually don't do anything here.
Okay.
So that's why surgery or glasses still remains the main treatment when we think about how do we treat INS patient in the Australian landscape, at least. Yeah.
Okay, great. And where is the lesion in INS?
Don't know. That's $1 million question. There's been a lot of eye modeling, and biomechanical engineers have worked on a lot of eye modeling. Where exactly, what causes this? We don't know. If we know, we can treat it. It's a bit like, it's a bit like, can't treat glaucoma like permanently. We don't know. There's a lot of people have postulated it's a saccadic pathway being abnormal, or smooth pursuit, optokinetic, vestibular. All this system has been modeled to say they're abnormal. But one of the issue here is that they cannot replicate all the 12 different waveforms of infantile nystagmus syndrome. So all this postulated eye modeling is still being speculative, but we don't have a true mechanism or the lesion.
Okay.
Does it increase with age or other characteristics wasn't if not treated? No, they are variable, but age is not really. The waveforms can change with age, but whether you say it increase other characteristics, it may or may not. It may or may not, because the waveform changes, and some waveforms have better vision performance, some waveform not so. So it may or may not. So there's no certainty in terms of whether the intensity or other characteristics. if not treated, not necessarily, because the brain can adapt to it. So if they are not treated, depends on what you meant by treatment. We have got patients who have gone on their whole life not having eye movement recorded until they are 60 years old. So they have adapted how this works. I remember most of them have got an associated underlying visual disorder. So most commonly, fovea hyperplasia or albinism. So their VA is actually poor to begin with. In that case, it doesn't really matter whether it gets worse because their eyesight is severely compromised. They do develop adaptive mechanism, so they have known how to do their face turn, and they know how to cope with it. So yes.
Okay, great. And there was one question which was asking about how many of the nystagmus patients have albinism or vice versa. Is it very closely related in your experience, nystagmus?
It's very common. It's very common. The study by a body, I cannot remember the percentage, but it's quite common. Albinism and INS, it's common.
Yeah,
but I cannot remember that percentage on the top of my head. Yeah. And I think the question about Alexander's law, nystagmus patient does follow the Alexander law, but we talk about the law when it's more on the vestibular lesion. But if you want to know, it does follow Alexander's law.
Okay, great. So that's great. And is there any way to check the degree of the head posture in patients with nystagmus except using a goniometer? Any experience?
That's why when we do the eye movement recording, what we do is actually on the eye tracker, the eye tracker will give us the degree. So we know this is 5, 10, 15, 20 degree. Yeah. We used to use like an arc that will mount LED and measure where 5, 10, 15, 20 is. So this is more laboratory setting. I think clinically it can be quite tricky because sometimes they come with 25 or even 30 degrees. So it can be quite tricky. I can only say we rely on our clinical experience to say this looks like 5, this looks like 10, this looks like 15. But eye tracker will be the most definitive way to really pinpoint how much is that degree of head posture.
Right. Yeah. And I think nowadays there are a lot of eye tracking devices like VisaGraph, and I heard about the VisaGraph quite being famous these days. But again,
So in our clinic, we use the Tobii eye tracker. For people who are familiar with eye tracker, we use the Tobii eye tracker, which is very kid-friendly. But sometimes the refresh rate or the sampling rate of frequency sometimes might limit, there's restrictions on the recording. Most nowadays we use the iLink. It's called the iLink eye tracker. So that's the one that we've used it for. My PhD student has used the iLink tracker to record nystagmus patient, and that's the one we use clinically. And again, I'm not aware whether there's any other eye trackers that people have used. We've been whether Google glasses, we're thinking if there's a type of. So those eye trackers can work as well, but to be able to record nystagmus frequency, to be able to tease out all the characteristics or the features of it, it needs to have certain, capacity for it to do that. We can't just have gross inspection of it. So that's one of the limitations so far for some of the eye trackers.
Great. Okay. And one last question. This just came in directly on my chat. Any role of prism prescription, specifically yoke prisms, in terms of managing nystagmus? Have you have any experience on prescribing prisms?
Yes, definitely, definitely yes. Like I say, the head turn has to be really just a slight, just a slight one. It cannot be huge, but those type of, giving them, when I say about that, -1, the Optom base out, you can split 3.5 in each eye. That can actually help a lot. And what it will relieve is their neck, and their back shoulder, their posture difficulty, having to walk around like that, and because of cosmetic reason. So the prism glasses definitely worth giving it a go. That's why after you do your refraction in a trial frame, then put that prism in and see whether you can correct their head posture or not. But as I say, the moment you increase your prism, there's spherical aberration and it limits their field of vision. So there's to be discussion. It's trial and error. And again, first time, you don't have to think about getting the right amount of prism. You still want to prescribe the minimum, and there might be a period of adaptation before you increase the prism. But you reach a ceiling effect where you can no longer increase and the patients do not find any useful. That's why we still think the place of prism is best used after they've undergo their surgery to try and correct their head posture. Whether the surgery will increase their vision or broaden their null zone or reduce the intensity, whether it can fit all, it's all debatable. It depends on the surgeon expertise. So patient expectation has to be, realistic as well. Their type of waveform, how large the tilt is, whether, how bad their vision is, whether they got any underlying visual disorder. You actually have to take all this into account, the whole clinical profile for you to make an informed decision, and you might not make the best decision at first instance. So communication is so critical, because the last thing you want is patient coming back and saying that you refer me for surgery and it makes my eyes worse and I can't see better now, or I'm not feeling any different. So that communication is really, really key. Yes.
That's right. Okay. So I think with that, Dr. Cham, we have taken most of the questions. Thank you so much for giving us sharing the expertise and giving us your time, and thank you from the attendees as well as from the team online Optom Learning Series.
Yeah, no, thank you so much. I hope you find this useful. Thank you so much for spending the time with me. Thank you, and thanks for the invitation. Thank you.
Most welcome. So please join us next week. I hope to see you all next weekend. Until then, take care, be safe, and bye-bye.